Greetings and welcome to the Lifestar March pre-training podcast. The topic for March is going to be the obstetric exam and fetal neonatal circulation and some of the adaptations the fetus has to make as it progresses to a neonate in that process of birth. But for the focus of this podcast, we're going to talk about the obstetric exam. The fetal neonatal circulation will be discussed at each core training by a selected provider at each station. So let's talk about the OB exam. Now we do a fair number of OB calls, and the majority of those are because that patient presented to a hospital without an NICU around that 35-week mark, 36-week or possibly even before that. And so now this patient needs to be transferred to a hospital with a NICU. So I like to break down this exam into two different components, the mom and then the baby. So let's start off with the mom. What do we want to know about the mom before these transfers? And so this is going to take place usually when we're talking to the RN and getting our report. So I want to know how many times has the mom been pregnant? And this is represented with a G or called gravida. And so we can document this, how many times the mom has been pregnant, and then how many of those pregnancies have carried to birth. And so that is represented with a P or para. Now here's where we start getting to the important stuff to let us know how hard we got to push that gas pedal. No, I'm just kidding. But it is information that is important about the imminency of this labor and how fast this baby is coming. And so some of the things we want to know are the station. So the station relies to the fetus head in relationship to the mom's pubic bone. We also want to know how far dilated the mom is. So fully dilated is 10 centimeters. So as we get closer to that 10 centimeter mark, we know that the mom is getting closer and closer to delivery. Now, the other thing that's important is to look at how thick the cervix is. And so the nurse can relay this information on to us. This isn't something we're checking ourselves. And we want to know a usual cervix is about 2 centimeters thick. And as that gets thinner and thinner and thinner, that means that delivery is getting closer. And so this is usually represented in a percentage. So you hear the mom is 5 centimeters dilated, 25% effaced. And these are all things that we want to document in our charting. Now, let's try to figure out what do we want to know about the mom's medical history. So there's a couple things that I think are important to know about the mom's medical history. One is, did she have gestational diabetes during her pregnancy? So we know gestational diabetes usually means a bigger baby. So that's important finding, and that's important to note as well. Does the mom have any cardiac conditions? So a lot of the tocolytics and the smooth muscle relaxation medications that we're going to give to kind of delay those contractions can cause some dysrhythmias and tachycardia. And we'll discuss that in a little bit. The other thing that we want to take note of is, did the mom get diagnosed with group B strep? And this isn't too important for us, but it usually means we're going to have an extra drip. We're going to have an antibiotic hanging as well. And then lastly, has the mom presented with any signs of preeclampsia, hypertension, low platelets, any abnormal lab values or electrolytes that we need to be aware of prior to transport? All right, so now let's take our focus over onto the baby. So we want to know, where's the baby lying? What's its position in the mom? This can be represented as ROA, right occiput anterior, or LOA, left occiput anterior. And those both refer to the baby's head being in the downward position. Now, if the baby is breech, that's going to open up a whole new book of complications. There's 3 different breech presentations. There's a Frank's breech, there's a complete breech, or a partial breech. We don't really know that until the baby starts to come out, but they will know the baby's in that breech position. So that's important to note as well. Now, the single most important finding is going to be the variability. So the variability, I'll admit, this is something that I have not always checked. And it's because I think I just didn't know how to read these graphs. But when you walk in, the mom's got those waistbands on, right? So they got the waistband on, and it's kind of measuring the strength of those contractions. And you look on the ground, and there's a big pile. It looks like a big pile of receipts, and it's those papers that are continuously printing as the mom has contractions. Well, if you look at that paper, on the bottom part is going to be the contraction. And so if you look at those contractions, find one, and draw a line right down the middle of it. So take that line right down the middle of it, and now look above it. And above it is going to be the fetal heart rate. So what we're looking for is decelerations or accelerations, but accelerations are not as concerning as decelerations. So when we look at these decelerations, we want to know, are they occurring before that halfway mark or after that halfway mark? And that's going to kind of let us know how the baby's doing. So if you notice that you have a drop in heart rate prior to that halfway mark, that's called an early deceleration. That's absolutely normal. If there was a good, bad, and worse, this would be the good one. This is very normal in those later stages of labor where the mom's or the baby's head is located in that birth canal and it's getting compressed during these contractions. That's normal, nothing to be concerned about. Now, the one that we should be a little bit more concerned about is the late deceleration. So like we said, if you draw that halfway mark right in the middle of the contraction and you notice the baby's heart rate doesn't drop till after that halfway mark, that's a late decel. And with those late decelerations, we need to be concerned about fetal hypoxia. And we'll explain exactly why during March's training. Now, that would be the bad one. Now, the worst one that should make us really concerned about the fetus's health and oxygenation would be variable decelerations. So variable decelerations, I want you to think of a third-degree heart block where the top of the heart and the bottom of the heart are not talking to each other. We got P waves doing their own thing. We got QRSs doing their own thing. This is basically what we're going to see with a variable deceleration. So you're going to notice contractions, and then you're going to notice the baby's heart rate dropping, but it doesn't really care where it's dropping. It's not in relationship to the contraction. And this should make us think there might be some uterine insufficiency going on, and we need to investigate this further. All right, so those are the different types of variabilities that you'll see. Let's just define bradycardia and tachycardia in the fetus. So bradycardia would be under 120 beats for over 5 to 10 minutes. Tachycardia is going to be anything over 160 for over 10 minutes. And those should make us worry either way as well. Now, a lot of the medications that we give are to prevent these contractions. So I want you to think of, back to chemistry, what makes a muscle contract? And that would be calcium, right? So a lot of these medications are preventing calcium from getting inside that cell and causing those muscular uterine contractions. So let's focus on the one that we see the majority of the time, which is magnesium. So magnesium is usually given in a 4 to 6 gram bolus over about 30 minutes. And then they'll have usually it's 1 to 3, it could go up all the way up to 4 to 6 grams per hour. So they're going to have a bolus and then they're going to have a maintenance drip. Now, magnesium works really well, but some of the things we want to monitor on that patient is their cardiac rhythm. We want to make sure we get a 12 lead on the patient. And the other thing is to make sure that they are maintaining their deep tendon reflexes. So deep tendon reflexes are something that we probably don't check on the ambulance, right? We don't have a reflex hammer. I think it's something that we should start checking. And so we're actually investigating into looking and getting some of these reflex hammers because there's actually some reflexes you can check on the hand, on the wrist, on the arm. That'll let us know, are we mag toxic? Are we hitting that mag toxic level? Now, some of the EKG changes that we'll see on a patient that is becoming mag toxic is a widened QRS. So that QRS is going to slowly get wider and our PR interval is going to get prolonged. And the reason for that is to think about what the AV node is made up of mostly. It's mostly calcium channels, if not all calcium channels. So as we block that calcium from entering with that magnesium, we're actually going to prolong that refractory period of the AV node as well. And you're going to get the prolonged PR interval, a widened QRS, and sometimes bradycardia as well. Now, if we notice that we have some bradycardias or we notice that the patient is losing those deep tendon reflexes, it's important that we administer calcium chloride or calcium gluconate to kind of restore that calcium supply. A lot of times the nurse will give you calcium gluconate to take with you on transfer. I know my service, or our service, we carry calcium chloride. And so can you give calcium chloride through a peripheral IV? You bet. Just make sure it's patent, monitor it, watch for any extravasation, but look at that. As long as you're monitoring it, it's completely fine. You can give CACL through a peripheral line without any issues. Now, the other medication that we're going to see administered is terbutaline. And so terbutaline, usually given sub-Q, all the time sub-Q. It should never be given anything but sub-Q, and that's going to be 0.25 milligrams. They're going to give that sub-Q most of the time before we even arrive for the transport. But if they haven't given it and you're starting to worry that the contractions are getting closer apart and you already maxed out your mag, you got your mag running out, then we can consider giving terbutaline as well. It is a medication that we carry at Lifestar. So terbutaline, if you were to look at the chemical structure of terbutaline and the chemical structure of epinephrine, they almost look identical to each other. There's just a couple little differences, but they almost look identical. So knowing that, what do you think that would do to the mom's heart rate? Bingo. It's going to accelerate the mom's heart rate. It's going to accelerate the baby's heart rate as well. So that's important for us to note because it's going to be an expected finding on the mom. So, we're transporting and the mom's got a heart rate of 120s, 130s, in a patient that has not received terbutaline, that might make us a little bit more concerned. But if we know they got that terbutaline, we're expecting that tachycardia. And like we said, that will cross that placenta and will increase the baby's heart rate a little bit as well. But what do we give terbutaline for sometimes? Asthma, because it's got the smooth muscle relaxation, and that's exactly what it does to the mom. It's going to relax those muscles and slow down those contractions. So I think we've covered the majority of the stuff that I wanted to get across in this podcast. The only other drip you might see is an antibiotic. That's not really going to affect us that much. The antibiotic can usually be turned off in the room and restarted once we get on transport. So I look forward to going through all this stuff with you guys in March. We got some fun exercises planned. We're going to really hit hard on that deep tendon reflexes and some of the things we want to check with that as well. I will not have a training in April because training is going to be our skill fair month, but we are discussing doing some sort of webinar. So I don't know, me and Sam and some of the field educators have been talking, and we're going to try to put together something fun for the month of April. So if not, we will be back in May with you guys going over IV administration or IV access and medication administration, and I look forward to seeing you guys all in March. So take care and have a great day.